hard work. Before we hear him, I would like to invite, along with my co-chair, first introduction by Dr. Gohan Ramurthy about Dr. Nirmal Surya. Thank you.
Respected Chair, dignitaries on the dais and dignitaries of the dais, delegates, it gives me immense pleasure to introduce the President of the Indian Stroke Association, and more than that, immense pride and honor to introduce my mentor, Dr. Nirmal Surya sir. To just introduce him would not be a true tribute, rather a 10-minute biography. I requested him for an extra minute, he said no way. So 10-minute biography of 6 shades, many legacies, one name and one soul. Once upon a time, in 1956, in a place called Earth, in a faraway place in Jodhpur, near the fort, the legend was born. Little did he know at that point in time, he was going to impact billions of lives across the globe, including mine. He was a very studious person with an inquisitive mind. Jodhpur it is. That's where the legend was born. From around the fort, he used to go to Sardar School in Jodhpur for his schooling. And this is the aerial view of the school. And from the school, after his 12th, he moved to SN Medical College for his undergraduation and MD Internal Medicine. These are the unseen pictures of Dr. Nirmal Surya. Gems. These are during his early days, early career, during the MBBS MD days. And then the king started his march towards Mumbai. Mumbai it is from Jodhpur. In Mumbai, he did his DNB in neurology in Bombay Hospital. And the big boss arrived in Mumbai. So he's currently the consultant in Saifi Hospital, Mumbai Police Hospital, and also he is the chairman of Surya Neuro Center, associate professor of neurology in Bombay Hospital and Research Center. He's fellow of Indian Academy of Neurology, fellow of American Academy of Neurology, and I would like to present the 6 faces, rather the 6 shades of Dr. Nirmal Surya. He is a visionary leader with no doubt. He is the ambassador of One Neurology. He is the Lancet Commission on Neuro-Rehabilitation. He is the president of the Indian Federation of Neuro-Rehabilitation. He is the past president of Indian Academy of Neurology. He is the president of Indian Stroke Association. He is the president of Asian Oceanian Congress Society of Neuro-Rehabilitation. He was the regional vice president, and he is the vice president of South Asia of WFNR. He was the member at large, the current chair of the Developing World Forum, and he further grew and is currently the Secretary General of the World Federation of Neuro-Rehabilitation. And these are the photos where he was appointed, and coming to the second shade, that's the compassionate healer. He has impacted thousands and thousands and millions of lives directly through his free epilepsy clinic, and if you enter his clinic, you can see the amount of love his patients shower for him. And amidst this busy time, where every second is worth more than a diamond, you can see still he spends his time in free clinic and he sees the patient himself. And this is the true empowerment of the patients, where the true healing begins, when not only we treat the disease, but also empower the patients. He gives them the livelihood. He makes them earn for their living by doing several crafts and arts. During the times of COVID, when I was actually trying to save myself from the COVID, he looked further ahead to see how he can connect with this patient, and that's when he started adopting the tele-rehabilitation, and he continues to do so in the current times when he's away from Mumbai and impact their lives. He is a great educator and a mentor. He is associate professor of Bombay Hospital and Research Institute, adjunct MAHRC research faculty in University of Toronto. He is appointed as the professor of neuro-rehabilitation in Pacific Medical University, the first professor of neuro-rehabilitation in the country. And in case you're wondering which conference has this extensive schedule? Let me tell you, this is not the program of one conference. This is the program of the commitments of Dr. Nirmal Surya in one conference. That's the World Congress of Neurorehabilitation. In just one conference, these were all his commitments. So that's the amount of work he does even in a single conference. So please pardon me, it's not possible for me to present all the presentations and publications of Dr. Nirmal Surya here, because you can see the amount of work he does in one conference. And these are the various webinars he organizes. And not only it gets ended with that webinar, it is available for all of us to see these webinars free of cost, so that we can learn further from what we have missed. And the one that's very close to my heart, the mentorship program, the best mentorship program, building neurorehabilitation career for young minds, enhancing future generations, shaping our character, training future leaders. And what we feel, all of us, his mentees are, it's just not a mentorship program, it's a movement, and it's a bond for life, a legacy passed on neuron by neuron and soul by soul. And he also made the senior professors and the legends across India, the voice of them, heard the talk show on the legends of neurology. He is an innovator and a trailblazer. No doubt he laid the inroads for the neurorehabilitation in the country. He is the founder president of the Indian Federation of Neurorehabilitation. He is currently the chairperson of the Institute of Human Behavior and Allied Health Sciences, IHBAS. He still finds time to share it with young engineers, to share how to develop low-cost rehabilitation. He is an excellent philanthropist and advocate. Through his epilepsy camps, he has impacted the lives of 35,409 patients up till date. That's through 106 camps, and these camps are complete with multidisciplinary team catering to the rehabilitation needs of the patients as well. He further empowers them, participates in public awareness programs, and rightly so, his name was published in the Forbes Leaders in Healthcare. He was recognized for his outstanding contributions. And he does public awareness programs. The most important is Neurons Ki Awaaz. He gave voice not only to the neuron, but he made the voices of the people echo across the world. And rightly so, he was awarded the Patient Advocate of the Year Award, Kenneth M. Wistage Jr. MD Award by the American Academy of Neurology. And this year he is receiving the AAN Volunteer Service Award. The global ambassador, not only India, he impacted across Asia, in Mongolia, Pakistan, Bangladesh, Sri Lanka, Maldives, far beyond Asia, Romania, Azerbaijan, Istanbul. He laid inroads into the World Federation of Neurorehabilitation. As well from India, we had 3 speakers in AOCNR. He had a huge impact on that. And across the globe in WFNR, under the impact of Dr. Nirmal Surya sir, we had 32 speakers from India at the World Federation of Neurorehabilitation. We have 6 chairs in SIG from India at the World Federation of Neurorehabilitation. And he is a man of words, rightly so, as he uttered these words while he took over the presidency. Right now, he is the mastermind, along with his team, of course, behind the Mission Brain Attack. He is a man of time. When we go to the conference and the conference starts at 8, if the Nirmal Surya is not there, it's the clock which is wrong and not Nirmal Surya sir, and that is 100% true. When the world loses track of time, he becomes the clock, steady, wise, and always on time. In a world of almosts and maybes, he stands as the measure where purpose meets purpose and precision meets purpose, and excellence is the only standard. His leg never rests, his mind never stops. This photo conveys 2 things. If Dr. Nirmal Surya sir does not say he does not have time for health, no one else in this world can say that. So it's Nirmal Surya sir's message every day in the morning on the social media that we all need to get up and start concentrating on our health. And please don't say no time for health. And he uses that time to create public awareness through social media as well. My heartfelt thanks to Mrs. Seema Surya Madam Ji for being the success behind the successful man, Dr. Nirmal Surya sir, and Mrs. Nikita ma'am, the wonderful doctor Dr. Nirmal Surya sir has, and the wonderful family. I owe them a lot for giving Nirmal Surya sir to this world and impacting the billions of lives. Last minute, 6 shades, many legacies, one name, one soul. With a fire and heart and a vision grand, he forges new worlds with a steady hand. A visionary leader, bold and wise, turning whispers into battle cries. Against the dark where hope runs thin, he fights with faith, determined within. A compassionate healer, fierce and true, restoring strength where pain once grew. A mentor, a teacher, a guiding force, forging minds to chart their course. Not just knowledge, but the power he gives. A legacy carved in the lives he lives. An innovator breaking chains, turning struggle into gains, merging science with boundless care, redefining what's beyond repair. A philanthropist, a warrior bold, championing lives, a heart of gold. No voice unheard, no battle lost. For justice he fights at any cost. A global voice, a thunder strong, uniting nations, righting wrongs beyond borders, beyond time. His name shall echo fierce, sublime. 6 faces, yet a single name, single soul, a fire that burns, an unshaken gold, not just a man but a legend in stride. Dr. Nirmal Surya, a force, a guide. Ladies and gentlemen, I present to you the President of the Indian Stroke Association, Dr. Nirmal Surya.
Thank you, Dr. Ramurthy, for that wonderful introduction. And now we hear the man himself, Dr. Nirmal Surya, the legend.
Welcome, Dr. Nirmal Surya, and there will be no questions after the oration. It's a request.
Thank you, Guhan, for introduction. I think you have given my oration. Chair, Dr. Vijaya and Arvind, WSO President, Dr. Jairaj, teachers sitting here, Dr. Devika Nag, my friends from Lucknow, past presidents, Dr. Selja, Dr. Pradeep, Dr. Padma, Dr. Subhash Kaul, Shirish Hastak, the legend from abroad, Professor Anderson, the president-elect of WSO, my colleagues, my teachers, my friend, ladies and gentlemen. When you become a president, you always look for that I will give a presidential oration. And that become a sort of a landmark and a hallmark, both for you and your work which has been done. 40 years in Mumbai, exactly 84 I came. And when I look back what I was, that's the story. But we need to respect who made you this. Professor B.K. Goyal, the youngest Padam Shri, Padam Bhushan and Padam Vibhushan. I don't see any other doctor who has all the three with the Sheriff of Mumbai, was the one whom I met first when I came to Mumbai to become a cardiologist. But it was Professor Singhal who insisted that I must become a neurologist. Though I twice told him that I am not interested, I am interested in cardiology, but faith takes you there where it has to. The late Nandu Chhabria was the one who treated me like a son in Mumbai, and he was the great neurophysiotherapist. Many of you have not heard, but in 1980s, his theory of CSR, not the one which we are doing through the companies, cortico-subcortical relay, the base of the motor recovery was his idea, and my close interaction from 86 made me think about the rehabilitation approach to the patient. So I must give my gratitude to these great teachers who have made me what I am. So when I came, what I was, from clay, it was the clay which I was, and from the clay, over a period of year, it became a pot which could give and store the things and give it to the others. And the potter's choice, as you can read, a lump of clay within my hand, cold and formless, loose like sand, I stand before a silent choice to let it sleep or give it a voice. The stroke rehab just like this day, unshaped, unseen in India's way, no structure stood, no path was laid, no guiding hands, no kin was made. Yet in this mud I saw a dream, a vessel strong, a vital stream, not just care but hands to heal, not just hope but strength made real. So yet still the wheel must turn around, and for every life, for every view, the hand must mold, the fire must glow, the shape the world where hope can grow. This was the thought which worked on me. About neurology and stroke, for the neurologist and stroke patient specialists, for physician, building stroke specialists, the budding stroke specialist, multidisciplinary team which become part of the therapy, the patient and caregiver, and for society. I always have been thinking about all this together. The shaping of clay and making of an era started in 1985. And ladies and gentlemen, this was my first interaction. I was like a fool when I was working as DNB student in 1985, took the thesis of prospective study of intracerebral hemorrhage. And 130 CT scan proven cases, I took it as my thesis. And because of this choice, which may be wrong or right, I don't know, I could not appear in the exam for 1 year because my thesis was not ready. So it took me 4.5 years to pass my DNB, where my all colleagues became DM neurologists, including Sudhir, Ajit, they all were with me. But this study, if I look back today, and I want you to think about what work we have done in those 4.5 years, which became the base of my work for the last 40 years. A study was aimed on clinical study and CT scan finding in the intracerebral hemorrhage, and to evaluate the short-term prognosis of cause of intracerebral hemorrhage treated conservatively. This was the proforma which ran into the 5-6 pages. I would go to each and every patient CT scan. I will measure the volume of the intracerebral hemorrhage right on the CT table. So incidence as of in 89 when I finished my thesis was worldwide was 11 to 15%, while in India was 5.9 to 37.9%. Of course, historically it was described in 17th century, but this prospective study of 130 consecutive cases, the exclusive criteria was trauma, aneurysm, AVM, tumors, and coagulopathy. And among the demography, 81 were male, 49 were female, and average age was 58 years, ranging from 28 to 84 years. 127 patients were managed conservatively, 3 patients underwent surgery. The commonest symptoms were headache, vomiting, seizure, and coma on admission was seen in 30% of patients. The neurological deficit for hemiparesis was commonest, 78%. Quadriparesis, aphasia, and dysarthria were seen in 30%, and 36%. The location commonest was lobar, 34%, thalamic, 35.5%, basal ganglia, 15.8%, cerebellar was 11.8%, and pontine was 2.6%. 45% of cases has mass effect, and 35% patient had intraventricular extension. And these were some of the cases at that time which we have kept. Outcome, the mortality in that era in our hospital was 17.6%. And if you look at the ADL, the functional recovery, 20% patient made complete recovery, 20% had mild, that is ADL2, ADL3 was in 35.4%, and ADL4, that is severe disability, was in 7%, with 17.6% died. The conservative management key component were blood pressure control, use of anti-edema measure, both mannitol steroid, prevention of infection, but mind you, early mobilization. So that point of time, I learned that early mobilization is the key for the rehabilitating these patients, even with intracerebral hemorrhage. And outcome was 17.6% mortality. 3 patients who were operated, there were indications of large hematoma with more than 20 square centimeter and deteriorating level of consciousness, and cerebellar hematoma if it is more than 3 square centimeter. Out of these 3 patients who underwent surgery, 2 died and 1 survived. The 35.4%, as I said, IVE prognosis was 39.1% mortality in those who have IVE extension and 73.3% mortality in comatose patients who have intraventricular extension. So our conclusion was that intraventricular extension is a poor prognosis. The complication, pulmonary was 20%, UTI 35%, GI bleeding in 26%, and renal dysfunction in 13.8%. And tracheostomy was done in 8 patients and peritoneal dialysis in 2 patients. So prognostic factor, higher in patient more than 60 years, hypertension in 81.5%, comatose patient 38.5% mortality, and hematoma size more than 20, 60% mortality, less than 20 is 7.6. If you look at this chart, those who died because of hematoma, they died within 7 days. You can see that less than 2 days, 7, 2 to 7 days, 7. But those who survived after that, they died because of related complications. And if we compared with other studies across the world, it was slightly higher than global incidence as per Jellinger. Rest all other match with what was the international data at that time was existing. And we have insight into these hypertension, CT scan role, complications, surgical versus conservative, pre-CT and CT era. So mortality dropped from 50 to 70% pre-CT era to the 17.6%. So CT made a difference in outcome of intracerebral hemorrhage, and I think that was an important point we learned. So what are the key conclusions? Mortality rate 17.6%, hypertension and age less than 60 years significantly, more than 60 years significantly increased mortality, level of consciousness, hematoma size, and intraventricular extensions are critical prognostic factor. Conservative management is effective for smaller hematoma. Surgery may benefit larger hematoma. What I learned from this study, I trained the nurses. So all my patients who were in ICU, we have trained 20 nurses. None of our patients can have any other nurses except those nurses. I would allot them. They were trained how to turn the patient, how to make the patient sit on the bed, edge of the bed, when to move out of the bed to this patient. This I'm talking, ladies and gentlemen, 85 to 89. And that was a result that our mortality and patient going home was better. But I realized why stroke care is crucial in India. High incidence and mortality, burden of disability, limited awareness and delayed treatment, gaps in infrastructure and access to care, and need for stroke rehabilitation and the long-term care for these people who are in disorder of consciousness. So these are the challenges which I think is still existing till today. So then the 89, when I passed out, I presented this paper in the World Congress of Neurology, New Delhi, and it was very well appreciated at that time. Now, there are certain firsts because of this background of experience of ICH, and I'm just going to share with you that they will look a little bit adventurous, but I did. There were certain firsts which I did. IA thrombolysis 1998. Many of you might not have even done your DM at that time. Botulinum toxin, moving from movement disorder to spasticity for post-stroke, stroke rehabilitation, and mission brain attack, the latest of that. This was the paper which I got. Those days I did not have, I was doing private practice. 1998, the patient came, young patient, doctor, from the media. He was one of the reporter for one of the very famous channel in Mumbai channel, and he developed, while he was interviewing a politician, unable to speak clearly and some hand weakness. And the politician called me up that I think this patient has got stroke, I'm sending him to you. He came in 15 minutes. We did a CT scan. There was already could see that he is developing a large infarct. Those days we did not have CT angio, so we, on that CT, MRI also was not available, and we took him straight to the DSA. I spoke to Srinivas Desai at Just Look. He said, let's do that. We did a DSA, there was MCA occlusion. We waited for 1 hour because his wife was in suburb and she has to come and give the consent. So we kept the catheter. The moment she came signed, we gave 5,000 units of urokinase. And the patient, within 15 minutes, walked, his speech improved, and we continue his rehabilitation at Nair Hospital. He did much better and he went back to the work. So that was the first encounter of mine with intra-arterial thrombolysis when it was just begun. In 2002, I got another patient with large aneurysm come from Oman, and we said what we can do. The patient was not fit enough to undergo the surgery with that mortality. So we did this GDC coil in 2002 in a private, and you could see that patient improved significantly, and he went home walking. So these are some of the cases which encourage us to do the things which we can available and take some risk in those era. Botulinum toxin, the first toxin in India, I imported in 1992 from London. I remember this port, 2 vials to come together, and we imported it and started for the hemifacial spasm and blepharospasm. From 1992 till date, I must have had more than 1,000 patients being treated, presented at various platforms. But in last 15 years, I have moved on from movement disorder into the spasticity. And some of the cases in 2000, this one case, I particularly want to show you, one for the spastic hand and one for the
page video. Just उधर से
hygiene.
और करिए थोड़ा थोड़ा और.
And these are very gratifying because this gentleman who was not able to use his hand, not able to open, within few weeks, he started doing better, he started walking. He first in 10 days, he said, doctor, now I can jump into the train and climb because of, I've done nothing for the leg, but his leg improved because he was able to make better balance. And we needed to give him a second dose after 6 months because of the wearing off of the effect. And we gave a second dose. And at 6 months, he was able to use his thumb and switch on, switch off. And he could use the glass. But he was not happy, so we gave a second dose. And you could see at 1 year, he came on the day of Diwali, he was able to write. He wrote a letter, Happy New Year to me. 25th October 2005. This was the gratitude because his therapist said, don't take botulism. His family said, don't take botulinum toxin, and I gave. And this gentleman was a homeopathic doctor who developed intertrigo and severe pain between the thumb, and we just injected in the hand, and he started using his hand. So these were some of the cases which we did. 2012, Abhinay is here, he was my DM resident. This gentleman in the ICU, on day 10, in ICU,
How difficult it is.
those days,
Yeah.
and you see the severe spasticity at myself. You can see he was in severe pain while we were trying. On 10th day, so on 7th day, I found that he's got severe spasticity. There's a severe pain he's getting. We injected him. And
Very good.
And you could see on third day, he was able to lift his hand. And this gentleman, he had a tracheostomy, and in 15 days' time, he was able to go home. So these were the early, there were no guidelines at that time that how early to use the botulinum toxin in stroke. And I believe that as early as 7 days, you can give the botulinum toxin. So these are the post-stroke spasticity data of nearly 219 patients whose data I could found out because I have more than 300 plus, but these are the patients whose data were there. Youngest was 2 years with infantile hemiplegia. Eldest was 94 years, 118 male, 101 female. Right side has been 123 cases, left side 78, and bilateral use in 18 patient probe, most likely the brainstem stroke, comorbidity for hypertension, diabetes, or both. And limb injected, what upper limb in 56, lower limb in 25, and both in 138 patients. And doses varied from 50 to 400 units, with maximum in lower limb 350 units, upper limb is 400 units, and minimum was 50 units. And the most common used muscles are, of course, you all know, I don't have to tell, these are from the data. So I moved on with these. I thought that we need to do the workshop, train more number of people, and there are not many experts available in those days. 2007, I organized first spasticity workshop. Then I was in Nair Hospital, started the first neuro rehab OPD in 2000 in India with a multidisciplinary team where OT, PT, ST, and psychologists will, along with the neurology resident, would be part of it. The Michael Barn, who was supposed to be father of spasticity at that time, was present along with David Goods, and we did this workshop wonderfully there. Then we did first International Congress in Neurology and Rehabilitation in Goa, where we did one-day full workshop. And since it was with the Association of Neurology of Maharashtra, we also had some cases with movement disorder. So we continue to do the Indian Spasticity Treatment, Assessment and Rehab Program, which is iStart, which will be dedicated only for spasticity. And I have treated, along with my team from the IFNR, and trained more than 1,000 neurologists, PMR specialists by now, who are using this botulinum toxin. Professor Gerard Francis, who is now the president of ISPRM, one of the legends in the spasticity and botulinum toxin, was one of the faculty in iStart 2020-216. These are many workshops which we have done all across the country in various platforms, including this was from Sri Lanka, that's from the Mongolia, where I've done this live workshop for post-spasticity workshop. We have been doing regular post-stroke spasticity workshop in Indian Stroke Association annual conference and in IFNR, where we have been training the people. When COVID came, everything was standstill. And fortunately, I'm being a Maharashtra police doctor, I had a card which allowed me to travel even on any place, on any day. Even I can go to the Mantralaya. So during COVID time, except the 29th, 30th, and 31st March, when there was a complete lockdown by Prime Minister, I was every day going to my clinic, 10 o'clock, and would attend the hospital. 4th of April, I started the webinar. The first webinar was on stroke rehabilitation, and it was attended by 1,476 people from all over the globe. And my webinar was so popular for 1 month, every day, from 4th of April to the 5th of May, I did everyday webinar. Time was fixed, evening 4 o'clock to 6 o'clock, and everybody would log in, and my webinar, Zoom would be blocked before even starting the webinar. So we started, this was the first where I could not get YouTube. And you could see that more than 5,000 people from across the globe, nearly 36 countries were attending this webinar. They were all free cost. We then moved on to do the special courses every week, because by the time I finished on 5th May, everybody was doing the webinar. So I stopped that. We started the various courses, and one of them was spasticity management course, which was 2 hours every week. And you could see that this was very well planned out. And my experience of reaching out to all these people across the globe, when I did a survey, we got the paper which was published in Frontier in Neurology, Education, Training and Practice of Neurorehabilitation in India during COVID-19 pandemic. And you could see that what we got is major rehab center in urban area, 30% have one or more multidisciplinary team member, education and training is subpar, monetary benefit for professionals are low, no advanced rehab center available in this country, and people have moved. Initially, there was no rehab, have moved from the physical to the tele-rehab. So that was something which came out positively, and we presented this also into the WFNR annual conference, and we presented a consensus statement of neuro-rehabilitation during COVID-19, and this was a guideline that how you should be dealing with the rehabilitation during that time. We moved on, redefining the pot, redefining the research. These are some of my work which has come. There are so many book chapters I have written along with my team into the various books, monograms for last 10 years or 12 years, which has been published on various platforms. I'm not going to talk detail about that. I think they all are available. The publications are also many. We have interesting cases like rapid recovery from subacute to chronic ischemic stroke following revascularization by carotid stenting. So this patient, when we did a stenting, on the table he started lifting his leg. So these are some of the experience which we published. The dry needle is something which is coming, and I wrote this editorial and then they presented dry needling in stroke. Those who are rehab therapists, they would know that how, like in acupuncture, you could do the dry needling to improve the spasticity post-stroke. Then rehabilitation in perception disorder in stroke. This is something which is not known. There are perceptual difficulties which are hidden, and they are the ones which are a hindrance to the stroke rehab. We wrote a very interesting review in Science Vogue, and these are some of the journal which publish our MRI negative cases. So there are a couple of cases which on stroke MRI were negative, which became positive after 24 or 48 hours. So we wrote about that. These are some of the embolization of AVM, rapid recovery following mechanical. This was the first time we used the, I forgot the catheter name. That was the first. So we used for the basilar artery. I forgot the name suddenly. So this also the patient completely recover from semi-conscious to complete normal with the rapid recovery. During COVID, we wrote, this was with Partha Ray, we wrote the neurology and telemedicine, the way forward, health system for rehabilitation. This is a critical operation for national program. This has recently been published in 2025, February. With Subhas Kaul and other neurologists, we formed a hypertension consortium, and we did this study where optimum management of hypertension and subsequent reduction in India, stroke perspective was discussed, and we published this paper. During the World Congress of Stroke, we published this data. The education and awareness and the need of rehab. And 189 neurologists we interviewed. And they responded that 58.9% responded, only 18.3% had dedicated stroke rehab center in this country, out of these 200 stroke specialists who were present last year. And there is a lack of specialized training in the field of stroke rehab for many professionals. And these are the costs. So that worried me, and I thought that I should make a difference in making out the stroke rehab. And you could see that total stroke rehab centers in India, which can be divided south, north, west, east, and central. And you could see that maximum centers are in South India and North India. And the east and central are really lacking. And among, if you look at 80% of them are in urban area. So we really need, as a stroke association, it is our responsibility that we should enhance this and get it at par to the world. So advanced multicentric are only in 30%. Basic rehab clinic are there now, 50% of cases. Home-based and tele-rehab, which is only 20%, and we can really push forward to this. This was my resident during his DM neurology. I asked him to take a ischemic stroke as one of the paper for his thesis, and he presented. And he also looked at 100 places during his 3 years tenure. And you could see that 3% was the only money spent, even in a tertiary hospital, on the rehabilitation. Average stay costs were at par with many other places. Another, my DM resident, Mehul, I asked him to look at swallowing as a principle. How many patients on admission has swallowing difficulty, and on discharge, how they are. And you see that 35% of acute stroke experience dysphagia. They were more common in brainstem, that is 62.5%, than in hemispheric, which is 37. And at discharge, 41% of hemispheric patient and 60% of brainstem stroke patient has persistent swallowing difficulty. And this is something which all of us has to learn to evaluate the swallowing in each and every stroke patient right on the day one and afterwards. Now, integrating art and artfully integrating the multidisciplinary team is something which I started. 2000, as I mentioned to you, Nair Hospital, I was there for 15 years as visiting professor and started a dedicated neuro rehab OPD. And there were many things which we were able to do that. And this was first neuro rehab OPD which was developed. There were resident, as I mentioned to you. We had a 54 pages assessment book. So OT, PT, ST, psychologists, everybody has to give their assessment, and I would make a program for them. And in that time, for those patients who are coming from outside, we have made a program, tele-rehab. And you will say, how you made a program? We will make the exercise on the patient's phone on the video. And we'll tell them to follow them. And when they come back after a month or 2 months, we tell them what exercise you are doing. You make a video and bring that, how you are doing. And then we'll see that, and if they were doing wrong, we'll correct them that this was the way you should do and add on to other therapy. So this is how we started the tele-rehab. These are therapy in the stroke in ICU. I started, and tilt table was something which every one of us should have, because it can make a great difference. This patient was made to stand on 8th day with this large intracerebral hemorrhage. This is something we innovated. The treadmill, which I was not using at my home, my wife will remember, I donated it to the Nair Hospital. And those days, the frame was costing about 8 lakh to 12 lakh rupees. So we made a wooden frame. We used these belts, and we use it to support the patient to make them walk on the treadmill training in 25,000 rupees. That was something, and you could see this stroke patient treated with botulinum toxin, and now he's been made to stand and walk on the treadmill. And this was where we started. We did a lot of experiments, and there are a lot of paper, particularly cerebellar ataxia. My paper is landmark paper for whole world. 2004 was the interaction where I did first as a guest editor for Saudi Journal of Disability and Rehabilitation. And our couple of papers like botulinum toxin, multidisciplinary team was part of it. Move on to that. How do we solidify it? The collaborations are something which we have done during the stroke last 1 year with the API. We have done joint meeting with the pediatric subsection of Indian Academy of Neurology, and international symposia are many. 2018 was something which was a landmark for neurorehabilitation in this country. I did the World Congress in Neurorehabilitation, which is one of the meetings still to be remembered. I got this letter from Prime Minister Sri Narendra Modi, and it was very heartening to learn from him. These are some of the Asian societies meeting, AOCN, which we did in 2022, and many of you were there when I was the president of Indian Academy of Neurology. Was most successful, and there were a lot of symposiums on neurorehab and stroke. ISA symposium at ASA 2025, recently Dr. Selja, Jairaj, Arvind, myself and Vijaya, we all were there, and that was very well accepted. And we are now having a sort of MOU to have every year joint session. We had yesterday here, and we continue to do this with the American Stroke Association. Firing the pot is very important, because that is something for the next generation. So future of neuro rehab, these are the collaborations which we started. And low cost make in India. And this is somebody who did a innovation. And believe me, this was done by a man who is not even 10th pass. He's from Goa. He works in one factory. He built up this robot for his daughter to feed her when there's nobody. And this costed 10,000 rupees. So I invited him. We invite this innovation every year in the IFNR and gave him 10,000. And we're building up on this. On that, we developed this AI-enabled rehab application with Manstick. And now we are partnering with Galanto Innovation, where we have developed a rehab active glove. And this is the glove, which is around 1.5 lakh rupees. It fits to 7 to 70 years of age. It has sensor at wrist, at elbow, and at the shoulder. It can control all the 3 exercises. And this can be connected with the VR, so you can do the VR activity. I've used it myself. And this is wonderful for the hand functioning, not only for the wrist, and this can be used as home therapy, so patient can use it at home. And now what we have also done is, new innovation is, we added the FES along with the game-based rehabilitation in this. So patient can use FES and do the game-based exercise to improve the hand function. And currently we are planning to have multi-centric trial with this glove at 5 centers across the country. We also work with Manstick to develop first tele-neuro rehab app for the multidisciplinary stroke care. It includes the cognitive stimulation therapy, occupation therapy, physiotherapy, speech language therapy, and nutrition. And this is the app which is available. We have been awarded a fund from the IIT Indore now, and we are working with that. Manstick, Mr. Puchraj is closely working with IFNR. We move on, Golden Book and Journal. This is something, a dream. When you are a teacher or when you are a neurologist, you always dream that when would I be an editor for a book, or when do I will have an editor of journal. Dr. Selja must be feeling great proud of editor for Journal of Indian Academy of Neurology. These are the 2 achievements which ladies and gentlemen, I achieved in last year. The textbook of neuro rehabilitation, only textbook in the world with 50 chapters, is available today, and this was released last year at WFNR in Vancouver. And the second edition of the Journal of Indian Federation of Neuro Rehab is now available. We are getting it indexed. There is no, this entirely is being done by me. There is no publisher. Nirmal Surya and IFNR is only publishing this. So we are working hard to get this better. The final polish comes, the support groups. The patients are to my heart. I love them. They love me. And 2018, the 9 support group, I got them involved in World Congress Neuro Rehab. Spinal cord injury, traumatic brain injury, multiple sclerosis, epilepsy, stroke, and ALS. And these 9 support group, various organizations brought them together. And 2020, and this Hastak was the one who was talking to the stroke support group, 74 patient came. And international speaker was Gert Kavkal, who is a rehab expert and botulinum toxin, various work. And then we did, during the AOCN, Neuron Ki Awaaz, as Guhan published, and 9 support group coming together, understanding the need for them. We published this white paper and gave it to the Niti Aayog to act on their requirement together. We involved them in various activities. We did various runs, walk. I run for epilepsy every year. And for last 3 years, during Mumbai Marathon, I'm running 10 kilometers for Epilepsy Foundation. And I must say that this year, I am very happy that I raised 47 lakh rupees for the people with epilepsy through my effort of the Tata Mumbai Marathon platform. So that's something which we are able to do. World Stroke Day, we have been doing a lot of activities, and every place we have been very active. We did a stroke day competition between IIT and IIM student. There are 190 entry, 10 selected for the presentation. The first prize was iPad, and the second prize was the Lenovo notebook. And it was very, very interesting the way they sent the picture and photographs. It was very inspiring. What made me very happy in last 3-4 years is I have been able to instrument in developing the Neuro Rehab Center. The first center was built up at Radiant Rehab Center in Amravati by the Sikandar Advani, and I inaugurated that. The second, the biggest in Mumbai, is Atharva Ability under the Lupin. Now they have got 3 centers across the country, and this center is doing very well. I had a pleasure to inaugurate with then Maharashtra CM Uddhav Thackeray along with other people, and it was something center is doing exceedingly well in Mumbai. And then couple of last year I went to the Sholapur to inaugurate yet another rehab center. It is not the end. I know that there are many more centers are coming in this country, and this is the way the young neurologists in rehab in remote area, in the Tier 4 and Tier 5 city should develop. As Guhan has already told you, I've been the mentor for the program, but it is these mentees who make me active, because they are the one who bring out new ideas and share with me, and these are some of the thoughts they have displayed, and I'm very thankful to them. All four are from India. I'm fortunate to have 4 because no other mentor has got more than 2. So these are some of the thoughts which they have placed, and I'm really thankful to them to have them together. They are like my own family, and we go together. Let's move to the final inspection. We need to value every contribution. Tele-rehabilitation is something which you have to understand. I think this is the way in this country, which is used with a population of 1.42 billion. We need to develop this. And these are some of the cases which we developed through the tele-rehab. This patient during COVID completely treated by tele-rehab. We did not even see, even exercise, therapy, everything was given on the video call on WhatsApp. And look at she stopped down while going to the Pune and sent us the walk, what she has done from grade 0 power. And this case is another one which shows that how the tele-rehab, this gentleman who wanted to be in the police, I saw him in police hospital, cannot afford, with hand weakness. And look at his post-Botox, which we did in workshop, and see that what he is today. And will you believe, he has been selected in the police now. He has passed the physical exam, and he has been appointed, he'll probably get one of the posting as a police officer in Mumbai. So these are possible. Family-based rehabilitation is important, so you cannot ignore tele-rehab along with the family. And this was the paper I wrote in 2019, much before COVID, that in our opinion, the advancement of tele-neuro rehab as an adjunct to family-based rehab will help the improving patient's outcome as well as reduce the burden of cost on the family, on the patient, family, and caregiver. I think that has come true after the COVID. These are many workshops I've done across the world on family-based, and Rehab Week, which is one of the biggest week. Last year in Singapore, we did a workshop on family-based rehabilitation. So finally, the master mission brain attack, where Arvind is part of it, and these were the objective of Indian Stroke Association. I mean, I don't have to say anything. If you have 2 minutes, just walk around the wall and see what mission brain attack is and how it has made the impact. And we went from countries to countries, cities to city, starting from the Varanasi, the holy city of Lord Shiva. And these are the 3 arms which is important, and we cannot ignore them. We need to give end-to-end care. Arm 1 is primary prevention, Arm 2 is acute management, and Arm 3 is long-term. We did printed this into the 15 local, Be Fast in 15 languages. These are some of the things you can see. But what is important thing is 3,000 physicians online and 1,800 physicians offline were trained during this mission brain attack, every place where we went. And look at that, 104, now it is moved to 106 physicians from May 24 onward has done the thrombolysis, including one of the testimonial is here from Lucknow, I think Dr. Pradeep, who has done 14 thrombolysis after he attended the Varanasi session of Mission Brain Attack. So I'm grateful that these people have confidence to use that. These are some of the testimonial. And we presented this into the plenary session. Arvind was there in World Stroke Congress, which was very well accepted. And Voice of Health also evaluated on our Mission Brain Attack, and it became very popular. Only one person knows the answer here. In stroke summer school, why did I put it? Dr. Vijay also knows. Somebody asked in the quiz, who is brand ambassador for stroke in India? And I leave this question open to all of you. You think about it. Let's move to the final part, molding the future. And that's what I look at. My presidency will get over, but my thought about looking beyond this will continue at various levels, including at international. I need to start rehab fellowship, and I'm very fortunate that with Pacific University, we are starting the rehab fellowship for 1 year for the physio OTST and 6 months for the DM neurology and PMR specialist, which will be starting this year, somewhere around May. Accreditation for stroke rehab, we are working, and this would be accreditation, true accreditation for the stroke rehab will start. Training for post-stroke spasticity for young will continue. Building the rehab institute is my dream, and I'm very fortunate that Dr. Damija gave me an opportunity to develop the rehab institute, which I spoke with Dr. Vinod Pal, and he said that there is a need, funds are available, we need a systematic approach, and we are working on that. Development of low-cost rehab equipment, we are working with a couple of IITs, IIT Gandhinagar, IIT Kanpur, and now with IIT Indore. And I'm sure with you all come around, we will develop low-cost equipment for rehab in next 5 years for this country, including my multi-centric trial and my expertise in the field of brain-computer interface. I tell you that I was zero. I was not understanding what is this IT people and engineer are talking. But listening to the people from Korea, Japan, Australia, Italy, I'm now learning how the BCI, and we are now developing 2 equipment for the BCI, which we are going to present the next conference, which will happen in India in September. The one which happened last month in Korea, I could not attend. So this is what I'm looking at. Everyone wants to leave a legacy. My legacy, my patient, my resident, and my work in stroke research. Genetically, we live through the children, but professionally, we live through those whom we train. May they get better and reach higher than I did. I thank you very much. My wife is very much here. She has sacrificed a lot.
Thank you very much for a wonderful
15 days I travel out of
presentation. Can we have a
Mumbai,
standing?
and really thank you to them and my inspiration.
Thank you very much for the wonderful oration from the primary prevention to the acute treatment to rehab. That is what is called as the comprehensive man of stroke. Thank you very much. Let's have the felicitation, please. Request one thing. This time, the whole executive committee, he pulled up everyone on the task. Can I request all of them to come up, please? It's an extra thing I'm doing this time, but I'll request the executive committee to come up on the stage. Dr. Anand Lulkar, if you are there. Yeah, yeah. Mission Brain Attack.
All have worked very hard. I'm very house to many of them.
Yeah. So I think he need his team to be up on the stage. Yeah. All are here. Yeah. This is the pillar what he has this year. Thank you very much. Thank you.
Thank you so much for such insights. And moving forward for our lunch symposium, I would request the chairpersons to please join us on the stage. We have Dr. Ritika Bharadwaj and Dr. S. Ghosh. Also, since this is a lunch symposium, the lunch is going to run simultaneously as long as our sessions.
Let everyone congratulate.
Okay, okay.